Ball State Community College's Respiratory Care Program. Today I will be talking about how to run a megacode in the event of a pulseless cardiac arrest. As soon as you determine that your patient is in a pulseless cardiac arrest, you're going to immediately start CPR. You will do 30 compressions to 2 breath ratio. You will give it the breaths on 100% oxygen. Then you will attach the defibrillator pads. As soon as the pads are attached, you will determine from the ECG monitor whether the rhythm is shockable or not. The shockable rhythms are pulseless VFib and pulseless VTach. As soon as you determine that, you will immediately shock. You will shock with 200 joules. In the United States, we use a biphasic shock, which runs from the right upper defibrillator pad to the left lower and back. This stops the heart in its tracks and helps it restart itself. As soon as you deliver the shock, you will begin CPR immediately. While you're doing the compressions and the ventilations, you want to get IV/IO access. After you do the 5 cycles or the 2 minutes, you will shock again. As soon as you deliver the shock, you are going to start CPR again, 2 minutes or 5 cycles, and then you will start by either pushing 1 milligram of epi or 40 units of vasopressin. These epinephrine and vasopressin are vasoconstrictive drugs. They help vasoconstrict the blood vessels, increasing blood pressure and stroke volume, just basically improving cardiac output. After you do that, you will need to consider an advanced airway just to make sure you're getting enough oxygen into the lungs to improve ventilation. You will determine, is the rhythm shockable? If so, shock. You want to increase the shock to 300 joules. As soon as you shock, you want to get back on CPR. Then you will consider delivering amiodarone. The first dose is 300 milligrams. Then after the next round, you'll push epi and then deliver the second dose, which is 150. Amiodarone is an antiarrhythmic agent. Once you get into this series of the algorithm, you want to start considering the reversible causes. These would be your H's and T's. Hypothermia, hyperkalemia, hypokalemia, pulmonary coronary thrombosis, cardiac tamponade. There's a list. You basically need to find out what exactly is causing the problem that's resulting in the arrest. Anytime you're delivering in a shock, you want to make sure that everyone is clear. I'm clear, you're clear, we're all clear before a shock is administered. The last thing you want to do is take out some of your team members. If you're not available to deliver the shock, you're going to go to the pulseless electrical activity, asystole side of the algorithm. Basically, you're going to give CPR, once again, 30 compressions, 2 breaths. Obtain IV/IO access. Give epinephrine every 3 to 5 minutes. Consider advanced airway. Is the rhythm shockable? No. Consider to push the epi. Treat reversible causes. Eventually, you need to determine when is the right time to call the code. If in the event of this, a pulse does come back, you're just going to go back to the VFib, VTach algorithm. If you do have spontaneous circulation, you're going to want to go to the post-care cardiac arrest, and this is basically going to be induced hypothermia and things like that. Also, just wanted to give you some information about monophasic shock. It is just one big jolt of electricity going from one side to the other. It's a little bit harder on the heart, so it's really not commonly used in the United States. The other type of shocks that will be delivered will be shocks synchronized, which is when you have a pulse, such as AFib and A-flutter, you'll give a shock of 100 joules. They have a pulse, you sedate them, and you deliver the shock on the QRS complex. And then, of course, since you're just delivering the shocks in these, when you